All right. This is the first episode of what we're calling our new agent podcast. So, the goal with this is to bring on new agents, have them ask the new agent questions or people who are just getting started. Hopefully, if you're a new agent watching this, that you can get some of your common questions answered, or even if you're experienced, that maybe you can learn something from somebody who's new in the business and just getting started. So, with that said, we have Jimmy Delano. He's our new agent. Jimmy just got his license at the end of last year. He started at the very end of AEP. Last 2 weeks sold 5, which I think is pretty solid for knowing nothing about Medicare and starting brand new at the end of December. Starting this year, how many do you have so far for the year, Jimmy?
Up to 12 now.
So up to 12 on your book total?
Yeah.
Okay.
12 total.
That brings
7,
you,
I think, post AEP.
Yeah, so 7 for the first month of the year. I think that's pretty solid for just starting out and just learning. Jimmy, what were you doing before you got your insurance license?
I was in the cell phone repair world.
Okay.
So it was a little sales oriented. So I was managing stores for Assurant. I'm sure you guys have heard of them. They do phone insurance contracts. Assurant does Verizon and AT&T. Assurant got the T-Mobile contract. I was managing repair operations for those. But they also there was some sales to it in that we had sold the insurance. So
okay.
that's the most sales experience
So
I have. Yeah.
did you fix phones? Did you sell the insurance? Like, what were you doing
Yes.
with that side? You did both?
Yep.
And what'd you do more of, fixing phones or selling phone insurance?
Oh my! When I was managing, I was literally doing everything. And that's what it ended up just wrecking me because I felt like we couldn't get enough people hired, and I felt like I was doing more as a manager. I shouldn't have been doing all the repairs I was doing. I shouldn't have been up front selling all the things. I should have been managing. But without staff, it's just.
So now we're moving from phone insurance to health insurance. Do you see any similarities so far?
In that sales, I would say that just building rapport with people and helping them, not trying to shove something they don't want down their throat,
Right.
but figure out what they need and delivering that to them. Customer service. Yeah, there's crossovers for sure.
So yeah, I'm super big on that. If you're gonna shove something down somebody's throat or be a scammer or be a hit and run agent, I don't want you working for us. I want people who are taking care of the customer and that the customer is more important than the commission or the marketing dollars or anything else that's out there. I think that's really important to have a customer first mindset, especially with Medicare, not necessarily all other insurances, but Medicare in particular. We're a renewal based product. So that means we're getting the same commission. We get it. The one-time commission is a little higher the first time, but after year one, you're getting the same commission every year on that client. So with that being said, you need to take care of that customer and do what's right. So you keep the client, you keep that renewal coming in every year rather than be a hit and run. You get a commission one year and you're just trying to churn your book every year. So I think that's really important. And you touched on that, that we're big about taking care of the customer, not just selling them a product or selling them what's going to get us the most marketing or co-op dollars. We want to really take care of the client and keep them long-term and keep them on the books from 65 to 85, 90, or, hopefully with life expectancies
Going up.
we'll be able to keep these renewals a little bit longer. But if you want to kick this off, Jimmy, if you had to say what your number one question about selling Medicare is, or getting started, do you have a top thing that you are confused about or that you need help with right now?
So I'm less confused about it than I used to be, but I've also asked the question over and over again, and I feel like I still can't completely grasp which is a better option for somebody. How do you determine if they're better off on a Medicare Advantage plan or a Medicare supplemental plan?
Yeah, I think that's a good question. So I think first thing is Medicare supplement is going to have underwriting if they're past age 65. So if you're not familiar with what underwriting is, that's when we look at people's pre-existing conditions. So if you're age 66 or 67 or any age and you want to get on a Medicare supplement, barring if you just retired and lost group coverage or barring some kind of situation that gives you what's called a guaranteed issue period, you're going to have to go through underwriting. We're going to have to ask your pre-existing conditions. What that's going to do is, number one, some people aren't going to get accepted for a Medicare supplement, so they're not going to be able to get one. Number two, if they do get accepted, they may have a higher rate. So the prices that they advertise on the website or from the carrier aren't necessarily the rate that you're getting if you have health conditions going on. So that's number one. So I explain that to people when they're turning 65 that, this is your guaranteed issue period. So I'll explain the differences between Medicare Supplement and Advantage to these people, and kind of let them decide and let them know that this is their time to get a supplement when they're 65. Past 65, when somebody's in their 70s, especially recently, they're almost guaranteed to get the higher rate now. So the underwriting is a huge obstacle on that, but just comparing what the difference is between a Medicare Advantage and a Medicare Supplement, basically when I explain it, there's two major gaps when it comes to Advantage versus Supplement. So the biggest one's going to be the hospital stay. So that's going to be the biggest copay on any of these Medicare Advantage plans, is the hospital copay. So generally it's a per day copay for a specified number of days. Once you hit that number of days, that's your maximum hospital bill. And then there is a benefit period that goes along with the hospital stay, where if you're readmitted, they're not going to charge you a second hospital bill. So depending on the plan, that could be anywhere from $1,200 to $2,500. So that's the biggest gap in coverage versus a supplement, where generally under a supplement, you're going to have full coverage when you go to the hospital. That's going to be the biggest gap in coverage between the two. For me personally, for a lot of people, the difference in price between a supplement and Advantage all makes up that gap in coverage. Plus, an Advantage is going to offer the extra benefits, things like dental, vision, hearing, over-the-counter coverage. So an Advantage plan is allowed to cover a lot of extra benefits over top of a supplement, where a supplement is just going to cover the medical and the hospital side. The other bigger difference, which doesn't come up a lot, but is if somebody is going through maybe like a cancer treatment or something like that. So on Advantage plan, there's going to be more out of pocket when it comes to cancer treatments. Luckily, in more recent years, a lot of the cancer treatments are generic, like the chemotherapies and the treatments and such. So they're not that bad on a Medicare Advantage plan. But what you can do with a Medicare Advantage is you can kind of fill in some of those gaps, like hospital and like cancer coverage, where you can sell them. They're called hospital indemnity or cancer plans. Which are indemnity plans as well, which help cover a lot of those costs if somebody goes in the hospital or unfortunately might get diagnosed with cancer. So you can fill in a lot of those gaps that would be an issue if or a concern for somebody that's going, that wants that extra coverage with a supplement, but also wants the lower premium, wants to take advantage of some of the extra benefits that come on a Medicare Advantage versus a supplement. The other difference between Medicare Supplement and Medicare Advantage is Medicare Advantage is a privatized version of Medicare. So Medicare Advantage, when the billing happens, everything is getting billed to whatever carrier that is. So whether it's United Healthcare, Cigna, Humana, all the billing takes place with the carrier, not to Medicare. And by law, they have to cover everything that the original Medicare program covers, and it has to be an equal to or lower cost than original Medicare. However, with a supplement, how that works is generally their first 80% is being billed to the original Medicare program. And then the other 20% portion is getting billed to the supplement plan. So there's two payers in that, where Medicare is the primary and the supplement's the secondary, where with Medicare Advantage, in most cases, there's just one insurance that gets billed to, which is the primary coverage. And that's going to be whatever carrier you choose for the Medicare Advantage side of things. So there's more differences between Medicare Advantage and Medicare Supplement. Medicare Advantage tends to be a more affordable option. And for most people, I think it's a good fit, barring if when they're 65 and they're turning 65, they have some kind of major condition or kind of like treatment they're going through, that it would make more sense on a supplement. But for the vast majority of people, I believe an Advantage plan is a good fit. And then if there are certain things that they have going on or certain concerns that they have where the supplement would have given them extra coverage, nowadays we can fill in most of those gaps with additional coverages to kind of fill the holes in. Hopefully that answers it for you.
Yeah. So Um, but with the Medicare Advantage, that's um Medicare C,
Yes,
and then D is prescription drugs.
correct.
But so I'm new in the business, but I have yet to see a Medicare Advantage plan that doesn't have some type of prescription coverage included. So
Yes.
why do they make so why is that part C and then part D is like drug coverage after that?
Yeah, so it's a little confusing, and it's confusing for the seniors too. So Part C is the Medicare Advantage, Part D is the prescription drugs, as you said. Now there are Medicare Advantage that do not include prescription drug coverage. So
Are they rare?
yeah, I mean every carrier for the most part has a Medicare Advantage only option. So that's generally going to be for people like veterans. So a lot of
TRICARE.
try people with TRICARE, people with the VA coverage. They can actually get their medications filled through the VA, and so then they can go on a Med Advantage only without prescription drug coverage on there, and they can get usually a better deal or some money back or something like that for choosing to not take the prescription drug coverage. The other time that we use that is for people who might have a late enrollment penalty for Part D coverage. So how I explain it to people who might have the late enrollment penalty, if it's only been a couple of years, the penalty to enroll in Part D late isn't that much money. So it's roughly $3.30 or $3.60 for every year you went without coverage. And that amount of your late enrollment penalty, that does get added to your monthly premium every month. So every month you pay that penalty. It's not a one-time thing. So the issue is if somebody goes, let's say, 10 years without coverage, now you've got a $40 penalty. And it's
Per
just
month?
per month. So the longer somebody went without a late enrollment penalty and whether or not they can afford to take the late enrollment penalty and whether or not they're taking medications that would make sense to actually pay for the drug plan plus the penalty. Um, for those people, we also might look at a Medicare Advantage only without prescription drug coverage on there. So most Medicare Advantage, they do include prescription drug coverage, but pretty much every carrier has an option without the prescription drug coverage on there. And the reason for that is people either have outside drug coverage or for people maybe with a late enrollment penalty. So that's gonna vary from place to place. So another thing to note is they call it Part C. For the most part, as an agent, we're not calling it a Part C to the consumer. However, in recent years, what they've started to do is run advertisements on TV
That's
about
where the confusion
Part
comes.
C, Part C. And now, especially during AEP, but I at least get a few calls a week now from somebody asking me what Part C is. Do I have Part C? Um, do I need Part C? And in a lot of cases, I already have them on a Medicare Advantage, and I tell them, hey, well, you already have Part C. It's just they're trying to trick you by thinking that there's some new Medicare thing out there called Part C. Um, but I really don't like that, but it's misleading to the consumer. But now that they're running those advertisements, we do need to let people know when we're doing the enrollment that, hey, just so you know, the plan I'm putting you on is a Medicare Advantage, but sometimes people call it Part C or they call it Part C on TV. And if you see that, just know you already have that. And we already set that up for you. So that's just the Part C. But does that clear that part up for you?
Yeah, and
Okay.
I think another potential segue maybe is so with Medicare Advantage, and you mentioned late enrollment penalties.
Yes.
Now, I think I learned through AEP on the job, isn't there subsidies that pay that penalty
Yes.
and pay the premium for those
Yeah,
Advantage
that's a
plans?
good thing to bring up. So if somebody has a late enrollment penalty, if they're able to get LAS or extra help, or in New Jersey, it's called the New Jersey PAD program. There's subsidies out there that pay the late enrollment penalty for you. They also pay the cost of a drug plan as well.
So to clear that up,
Um,
they pay because I just learned now that
yeah.
that penalty is monthly. Do they pay that monthly penalty
No,
or
their subsidy's going to pay the monthly payment for them. Now,
okay?
if they were to lose the subsidy, then they become responsible for the penalty payment as well. But if they, as long as they keep their subsidy and eligibility, they're good. So, New Jersey, we're really fortunate to have the New Jersey PAD program, which has a really high income limit compared to a lot of the subsidies that are available in other states. So, people can go up to $42,000 as a single individual. or they can go up to 49,000 and something as a married couple. And that gives them most of the benefits that the extra help or LIS is going to give them. The copays are a tiny bit higher on the drugs, but other than that, it's pretty much identical to extra help or LIS. So it's going to pay for any of the extra help or LIS qualified plans. That allows us, if somebody has PAD, to get them some of the better Medicare Advantage programs that are available to people with LIS and extra help. Gives us the ability to enroll them in the same plans and still have them paid for the same way that LIS or extra help would pay for those plans. The copays for them, all drugs get a cap on them, so the maximum they pay for any generic drug when they're on PAD is $5, and then the maximum they pay for any name brand is $7, and it takes care of any of those donut hole or all those extra stages of the drug coverage with Medicare as well. So like somebody like who's taking Eliquis or another drug that falls into the donut hole, the first thing I ask is, are you on a fixed income? Is that fixed income, under 42,000 a year? Because then we could just get you on a PAD and we take care of that whole Eliquis or any of the other donut hole drug issues.
Why don't we go over what the donut hole is?
Yeah. So, the donut hole is something that's on pretty much every single Medicare plan across the board. So, some people think that one carrier, has it, and I fell in a donut hole in here, so I better switch insurances or something like that. Unfortunately, it's something that's on every single Medicare plan across the board. So what the coverage gap is you first have I'll just go through the stages with drug coverage. Have your deductible, which is the first stage on the plan. Now, some plans have a deductible, some plans don't. Some plans take the deductible and they shift it to higher tier drugs only. So tier 3, 4, and 5 drugs might have the deductible on there, but then the tier 1 and 2 drugs, or the common basic generic drugs, don't have that deductible on. Then you go into initial coverage stage. That's the standard copays that are going to be listed on any Medicare plan. So whatever the tier 1 copay is this, tier 2 copay is that. The third stage is called the coverage gap or the donut hole. So what that is once what you've paid plus what the insurance company paid, once that gets to about $4,600 for the year, at that point, all of your medications become a 25% copay. So you're going to pay that 25% copay till you've hit $7,500 out of your own pocket. And then you go into what's called catastrophic stage. The copays go a lot lower. It's a couple dollars, or it's a 5% copay, depending on what's higher. But most people, they get into coverage gap and then they never leave the coverage gap. And the reason for that is because how you get into it is the total cost of your drugs, which is you plus the insurance company, total cost of the drugs. How you get out of it is out of your own pocket. So it's a max out of pocket until you hit that catastrophic stage. So for the vast majority of people, once they hit that stage, they're not getting out of that stage for the year. Unfortunately, that part is the same on pretty much every single Medicare plan across the board, unless you have a subsidy that's going to cover that coverage gap stage. So that's where the donut hole stage comes in. So a drug like Eliquis, for example, might be $120 copay for 3 months when you're on the initial coverage, but that drug around July, August every year, you'll hit coverage gap, and then you go to almost like $300 for a single month supply. So it's a really crazy shift, and then people might shop around plans. And then you get agents who either don't know or think they can get an easy sale by telling people that, it'll be cheaper on this plan. And we'll tell them, well, if you come to this plan, your Eliquis will be this the whole year. And they're quoting the initial coverage. They're not quoting what happens in the donut hole. I'm not trying to be cynical, but I think there's a lot more agents who know that they hit the coverage gap, or they're going to hit the coverage gap, and will just tell the consumer that they're not. And if they come to this plan, that they'll get the lower copay for the whole year, try to gain a client rather than doing what's best for the client. Because like as an agent, we have prescription calculators where we can just throw in prescriptions, and we know exactly what month somebody's going to hit the coverage gap, and we know how much it's going to cost through those stages through the year. But maybe if somebody's newer, like I don't know if you know how to access like a prescription drug like lookup and stages and all that. But if somebody's been in the business a little bit, they do know how to do that. And a lot of times, just agents telling somebody something to get a sale.
Then they ghost them.
Yeah, then they ghost them, and that's called a hit and run agent. But if you don't know how to do that prescription calculator, Medicare.gov does have a prescription calculator right on Medicare.gov that you can use, and you can put in someone's drugs, and it's going to give you the drug stages and how much the drugs will cost throughout the year. Certain times that's not accurate 100% of the time. So if you're getting like I've been doing it for a while, so I think Medicare.gov is easiest to do it on. So I'll run them on Medicare.gov, and I'm able to see if something looks out of the ordinary. I can run it on a different drug check and look. Every carrier has a calculator for you. I think Medicare.gov is more accurate than some of the carrier websites are for it. We have it through CSG. We have multiple different ways we could do a drug calculator for people, which I can go over with you at some point.
Yeah, that'd be great. Especially to see like where too that where it kicks in how much percentage they pay after they reach their 40,
So
you said
it's
4,500
generally 25%. Generally, sometimes that changes a little bit. However, again, you always want to check subsidy, especially when somebody's going to hit that. You always want to it's really good practice, especially that we're in New Jersey and we have the PAD program and it's such a high income limit. It's really good practice to ask every single person, hey, do you make under 42,000 a year? Because if you do make under 42,000 a year, then you can get on the PAD and we can get you a better plan. It's really easy for us to help them apply for PAD. And now once you've helped them apply for PAD, as long as you take care of them in other ways, they're really not leaving you since you helped them with a program like that.
Okay, well, that brings me to my next question. We talked about Medicare Advantage, talked
Right.
about prescription drug coverage. We talked about underwriting with supplemental.
Yeah.
So what does prescription drug coverage look like under a supplemental plan? Is there any?
Yeah, so the prescription drug plans they're all structured the same way. So they're all structured with that deductible, initial coverage gap, catastrophic. So that's all the same on every Medicare plan. And what changes from whether you're on a supplement or an advantage, they're all, for the most part, the Part D plans are pretty similar from one to the other. But where they change is whether or not they have the deductible, where that deductible is on the plan. So if it's on all the drugs or if it's just on some of the higher tier drugs. And then the formulary, which is the list of the drugs that the plan covers.
What about the tiers of drugs? So
yeah, so that varies from plan to plan. So something might be a tier 1 on, let's say, a United Healthcare or Humana, and then you go to Cigna, it's tier 2 or something like that. So the tier levels do change from plan to plan depending on which one you're on. Just what the best thing to do if you're going to do a supplement plan, you need to do prescription coverage, is just to run a calculator with all their drugs. And then it's the Medicare.gov calculator is going to basically get their full year cost. So it's going to basically get what they're paying for the plan plus what they're paying at the pharmacy for the entire year. It's going to add all that up, and then it's going to sort it by lowest total out of pocket for the year to the highest total out of pocket for the year. A lot of people will go and they're taking Eliquis or some kind of expensive drug that gets them in the coverage gap, and they'll go buy the most expensive prescription plan out there, or some agents will sell them the most expensive prescription plan out there. It doesn't do them a whole lot of good, because if you're paying $100 or $150 a month for a prescription plan, and then you're still ended up in that coverage gap, a lot of times when you're running somebody's prescriptions through that calculator, the cheaper plans come out to be a better deal than the more expensive plans, because even though they pay a little bit more at the pharmacy on the cheaper plan, what they paid for the plan, when you factor that part of things in, so if somebody's paying $20 or $30 a month for a prescription plan, has a little bit of a higher copay at the pharmacy, versus if you put somebody on a $100 prescription plan and they have a little bit lower copay at the pharmacy, when you factor in that they're paying an extra, $70 a month or something on the plan, a lot of times it's better to just do the cheaper option for them. So Medicare Advantage is going to be similar prescription coverage. That's going to vary carrier by carrier, but a lot of carriers will give you a better prescription plan through their Medicare Advantage, or at least better than what you would get on a cheaper plan, than what you'd buy with a supplement. But that's going to vary carrier to carrier.
So can you have both a Medicare Advantage plan and a supplemental plan at the same time?
I think you know the answer to this,
I
Jimmy.
think I do too. But some people might not.
You're right. But yes, you cannot. You can have one or the other. So, reason for that is a supplement is going to pay second to original Medicare. So, Medicare is going to pay the 80%, then the supplement's just going to fill in part or all the gap of the other 20%. On the Advantage side, now the insurance carrier becomes primary on that. So, everything has to be billed to that insurance carrier. So, you can't, because there's no 80-20 thing anymore. Once you go to an Advantage, you can no longer, you can't have both together. So you have to have one or the other. But yeah, if you didn't know, you can only have Medicare Advantage or supplement. You can't have both at the same time, and you can't have a standalone Part D with a Medicare Advantage plan, and that includes, well, this is going to vary. Like there's programs and some, but generally you can't have a Medicare Advantage only plan. So the Part C by itself that doesn't include the Part D, you can't have that with a standalone Part D. So you either have to do a Part C that includes prescription drugs, but if you do them without it, you can't go sign them up for a prescription plan to go along with that. Generally, like 95% plus percent of the time, that's the rule.
This might be a meme question, but
Okay.
how come the Advantage plan got the letter C and the supplemental plan didn't get any letter in the alphabet at all?
Well, so the supplements do have letters actually.
Oh, is that what E and G is?
So yeah, and there's, if you want to get even more confusing, there is a supplement plan C.
Oh, no.
So yeah, so basically the supplements are all standardized by the Medicare program. So if you bought an Aetna supplement plan G and a United Healthcare supplement plan G, they're identical plans. So regardless, when it comes to the supplements, all the different letters that are available for supplement, they're all the same carrier from carrier to carrier. That doesn't change regardless of which one you're on. Where it does change though, is the price, and then how the price goes up over time. So that's one of the things that gets a little bit tricky with supplements is typically the ones that are gonna, excuse my French, screw you over in the long run. With price are going to be the cheapest when you first turn 65. So there's a bunch of no-name carriers out there that will give you a super low rate on a Medicare supplement at age 65, only to be double the price of everybody else when you're 75. So that's just something to be. I usually tell people if you never heard of the carrier, you don't want to sign up for a Medicare supplement. They're probably going to jack the rate up, and those are the ones that have the lower rate. If you look at the reputable carriers, you look at Aetna, Cigna, United Healthcare, Humana, the big names that everybody has heard of, and you look at the price at age 65, they're super close to each other. The prices don't change too much from carrier to carrier on the supplement year to year. You still want to look at how that goes up over time, and usually they can show you at least a table or a model or a prediction of how that's going to go up over time. But that's the supplement. But the actual letter numbers with the supplement are all different. Are all standardized. I mean, with between the two between all the carriers that you're gonna sell. But I guess technically they don't have like a part this for a supplement plan in particular, because when it comes to a supplement plan, that's not actually like a part of Medicare. It's a supplement to your A and B coverage that you're already getting.
Yeah.
Right, might have.
No. I was going to say that does it actually make it more difficult to choose a carrier if you're set on a supplemental plan? If they use similar underwriting and the prices are so similar, how do you choose a carrier?
That's tough. So, I have a particular carrier that I would choose just because they're the largest. So, the thing with when it comes to the supplements is the way that rate is going to go up over time is going to be based on the size of the group and the risk factors of the group, and that kind of thing is they're going to look at, they're basically, whenever they do the rate adjustments every year, they're going to look at the risk factor for the group. So if you're in a small tiny company with not a whole lot of supplement members, well, if a percentage of them die or a percentage of them get cancer, that affects the rate for the overall group a lot more than if you're with one of the larger carriers.
Does the demographics of the group play a role in that?
Yeah, so that's one of the things you're seeing because right now is like a lot of the even from like reputable carriers when we got like rate adjustments at the end of last year, a lot of them were up like 15-20% year over year premium, like the rate adjustment. The reason for that is you just have less people who are getting supplements. A lot more people are doing Medicare Advantage. So the actual size of the group, even if it's a larger carrier, is just smaller than it was 5-10 years ago. Um, so the adjustments with whether people are dying or whether people are getting diagnosed with different conditions, that and the claims that the plans are having to pay out, it's just being spread across a smaller group. And so
Makes sense.
basically like supply and demand, that the plan's paying out more money than it was 5 years ago because they just don't have many members. So that's what's driving up Medicare supplement rates over the last few years.
So why are
Uh,
Medicare Advantage plans gaining popularity over supplemental?
so they're just better. So like 5 years ago or 6 years ago when I started, the Advantage weren't great. So the copays were a lot higher. It was a lot more HMO than it is PPO now. So that the doctors are more limited.
What's
Even
the difference between I think that's another thing
yeah,
too that like even a lot of agents who went through their course don't fully understand.
yeah. So even like well, real quick, like even like the copays, even if you did have somebody on an HMO today on a Medicare Advantage versus 5 years ago, the networks for those HMO plans are a whole lot better than they used to be. So it's just generally they're better coverage. There's been increases in funding for Medicare Advantage, which allows for better plans. So copays are lower, benefits are higher on them. It just comparing them side by side with a supplement 5 years ago versus today, it just makes a lot more sense for the consumer to be on a Medicare Advantage in a lot of cases versus where it looked like 5 years ago. But what was that other question you had, Jimmy?
So HMO versus PPO, what's the difference? What do they stand for?
Sure. So HMO is a health maintenance organization, and PPO is a preferred provider organization. Generally, the difference is that HMO for most services, except for outside of emergency or something of that sort, you have to use the carrier's doctor's network for most of your medical services. With a PPO, you can go outside of that network and still have coverage. However, the cost may be higher when you go out of network. The other thing is depending on when it comes to a Medicare PPO, depending on the carrier you're with, PPO could mean a really good thing, or PPO could mean not so good of a thing. Um, so just because it's a PPO doesn't mean that the insurance carrier that you picked that's offering a PPO is going to pay the doctor at the Medicare rate or above the Medicare rate. What that says to the doctor is once they've dealt with that insurance carrier, if they're getting kind of stiffed by taking you as an out of network patient, they may not be inclined to take that insurance carrier's PPO for out of network coverage if they're stiffing the doctor. On the other end, there's a few different carriers that always pay a Medicare rate or higher when you go out of network. In those cases, the doctors are happy to take the coverage because it would be the same as if you came with Medicare and a supplement. Those doctors on their end are getting paid the same amount. So just because the PPO, it doesn't, you want to look into the carrier a little bit and see what they're actually paying to the doctors. You don't just want to assume that it's a PPO and they can just go see any doctor. And you also want to look at the PPO and you want to look at what are the out of network costs on that plan versus the in network costs. Because a PPO is not necessarily better than an HMO for someone, because you might have one carrier that everything in their area they could possibly go to is in one carrier's HMO network. And then there's another plan where all the stuff that they go to is not in the network for that PPO, but you say, oh, it's a PPO, or the customer says, oh, I want a PPO because it's better, but that PPO does not include any of their doctors. So everything that they go to, even though it's covered, maybe let's say it doesn't, the out of network cost is so much higher. So an HMO is still a good option, assuming that the stuff that the people use or doctors they go to or the services they get, assuming that is, assuming their doctors all are in network, the HMO could be a better option than one of the PPOs. It just depends. But if somebody needs flexibility for one reason or another, the PPO is a little bit more flexible if they just want to have flexibility if something comes up. I would say if you're So the HMOs are going to give you, typically, the HMO plans from the carriers will give you better copays and lower costs. So, I mean, all things being the same, copays are the same. Benefits are, copays and benefits are the same. And then the doctors are in network with both the PPO and the HMO. Probably the PPO just to give them the extra flexibility. But I think that's why we need to be like looking at people's like needs, because you can't just blanketly say that one's better than. I'm gonna wrap this up with you, Jimmy.
Okay.
That's
A lot to
okay
take
with you?
in. Yeah.
Do you have any last words, final thoughts?
I would say,
And what's your goal for this year?
my goal is to do more events. I want to get out more locally in Gloucester County.
And what's your production?
Production goal? I would say 5 to 10 a week.
5 to 10 a week.
5 to 10 a week.
And what does that put us at the rest of the year?
5 to 10 a week. So that's 5 to 10 times 55 weeks.
Yeah, we'll say we have about 40 weeks left in the
40 weeks left in the year.
7 times 4.
28.
28. That would be 280.
Yeah.
Okay, let's do it.
Aim for the stratosphere. Maybe I'll make it to the ozone only, but we'll see.
All right, let's do it. Thanks for doing this podcast with me, Jim.
No problem. Thanks for educating me and lots of other agents in a similar position to me.